primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
I transitioned to DPC before I fully realized what it was. I was introduced to the idea by my soon-to-be partner, and I have been so thankful and so blessed to have fallen into this realm of medicine. I went from being rushed and overburdened and overwhelmed without having continuity with my patients, without knowing their stories or hearing their names, to be able to share their photos with me in the office of their recent trip or their new grandbaby, know their name, know their grandbaby's name, but also to be able to provide high quality medical care to these people and walk with them hand in hand through their journey in life. I'm Dr. Jillian Klaucke, and this is my DPC story.
Dr. Jillian Klaucke, MD, is a fellow in the Academy of Wilderness Medicine and is also a board-certified family medicine physician. She is also a Sandpoint, Idaho native. She joined Sandpoint Premier Direct Primary Care after gaining experience across the globe, beginning with medical school in Nevada, residency in Billings, Montana, work as an attending physician in Baltimore, Maryland, and traveling for general practice work in New Zealand. Dr. Klaucke has received specialty training in wilderness medicine and has been awarded, again, the Fellow in the Academy of Wilderness Medicine. Wilderness medicine is the practice in resource-limited environments, but may also translate to the office environment for travel planning or recreation advice. As a lifelong lover of outdoor sports, she finds that her avocation and vocation meet perfectly under this educational focus. Dr. Klaucke is passionate about providing whole patient care and helping pioneer a new direction in healthcare, thereby allowing for meaningful, lifelong relationships to develop between doctor and patient. She loves taking care of whole families, and she is very happy to return to Sandpoint, Idaho, with her husband and 2 children. Welcome to the podcast, Dr. Klaucke.
Thank you so much for having me. This is really great. I appreciate your time as well.
Well, I'm excited to have you share your story because for those of you who are listeners who might not have heard of Sandpoint Premier Direct Primary Care yet, the world of the Pacific Northwest is a very awesome place that a lot of people in my neighborhood have moved to during the pandemic. And so I think that especially with you being where you are geographically, but also getting this influx of people from different areas of the world, I'm really excited to hear what that has manifested in, not only from your time before DPC, but also now in this journey of DPC. So you being a Sandpoint native, where is Sandpoint, Idaho, and what is the community like growing up compared to what it is like now?
Oh, that's a great question. So Sandpoint is a very small town just 60 miles south of the Canadian border. So in the little skinny part up by the top, we're north of Coeur d'Alene, Idaho, and just northeast of Spokane, Washington, which is our closest international airport. But the town when I was growing up had a population of about 6,000 people in city limits. And now we're nearing 10,000, which is going to take us out of our category of small town USA if we were to pass that number. And the county's population has grown to about 40,000. So I know those are small numbers for a lot of listeners who might be in big cities, but for us, it's been a fairly quick growth. And as you mentioned, a lot of growth during COVID, where people were looking for more isolation and in a rural place to end up and be. So it's a great community. We have a lot of really lovely people here and nonprofits. And growing up in Sandpoint when I was a kid, we had a very wholesome childhood. Ride your bike to the little store to get the candy or show up to see your friends at the park 2 blocks away. And it was really lovely. And I always knew I wanted to come back here and raise my kids here. And somehow that managed to happen. The story unfolds. So I'm sure we'll talk about that a little bit.
It's awesome. I think that I think about this often when it comes to kiddos who are going to elementary school with my oldest, and my youngest is going to go in a few months here. But I think about people who grow up in a small town. There's that slice of doctors who are like, yeah, and I'm planning on going back to the small town or another small
Mhm.
town similar to where I grew up. There's something, it's not that there's something in the water, but there's something in the community that is very different than
Mhm.
living in a big city. And it's very interesting. I went to an elementary school where we had 60 kids from K to 8, and I had that small town feel, and that's what drove me to do rural medicine. So I love this
Mhm.
tie that you have.
Yeah. Well, I was really lucky when I was a little kid. My neighbor across the alley was Dr. Lawrence, and he was one of the 3 family physicians in town. And so he was my doctor. He delivered me at our hospital and my little sister, but he was also our friend and our neighbor. And his kids were my best friends growing up. So I always kind of knew that that was a possibility for me in this town. But he ended up becoming my mentor later on. And it was another component that made me think, this is where I want to head someday.
And that's pretty amazing though to have 3 family physicians just within your small town. I mean, even
Yeah.
just thinking about the numbers that you mentioned, that's really amazing.
So back then too, though, remember these guys were doing OB deliveries and appendectomies, and they were really doing full spectrum family medicine from birth to death plus surgery. And obviously, our specialty has changed since that time, but it was really, really neat to be able to see that so close.
So let's fast forward a little bit because you went from growing up in Sandpoint to then becoming a physician. And we haven't even gotten into your wilderness medicine fellowship. But when it comes to the fact that you were and I missed in your bio in California, then Nevada, and then Montana, and then back to Idaho,
Hmm.
tell us about your journey in choosing to be a family physician, because when we see something as a young child, very possibly, like, or I could easily see how someone could take that persona and take it with them. But then once we hit medical school,
Yeah.
there are people who change in terms of the trajectory of, I know I saw this and I love this coming in, but so tell us about your journey to becoming a family physician.
Great, great question. Not only through being in the same community as my doctor, Dr. Lawrence, my grandfather was a family medicine physician at the University of Minnesota. He was actually really helpful in getting family medicine designated as a specialty in the 60s and 70s and spoke to Congress to try to get rural physicians into rural areas. So he founded the RPAP program, which is a lot of what rural rotations in medical education is based off of now. His name was Jack Verby, and he was pretty powerful guy in my life as well. And he always encouraged me and said, you really should be a family doctor when you grow up, just like me. And I said, oh, okay, 6 years old or something. And it was really funny that I was lucky enough to remember that, but then end up ultimately having the grit and gumption to do it. And just like you're saying, sometimes people change their trajectory in education. When I went to medical school, my first rotation as a third year was plastic surgery. And I said to myself, I'm going to be a hand surgeon. Look at this. This is amazing. People come in with disability and they're fixed and they can move their hand after they have been stuck in flexion for 3 years or whatever that looks like. So that was my first rotation. Then I was on VA general surgery rotation. This is amazing. I am going to be doing these thyroidectomies. I love these hernia surgeries. This is so cool. And so on and so forth until I finally got to my last rotation of third year, which is family medicine. And I went, okay, you love everything. This makes so much sense. Welcome home. And it really just felt right to me. So it was an easy decision to head back towards family medicine, which is what I had intended upon doing entering school. At the University of Nevada, they really do put a focus on rural medicine. Nevada has a lot of small towns with a big need. It's not just Reno and Las Vegas, but they also accept kids from the WWAMI program. So Washington and Alaska and all those programs over the West. And they want to get those students and ultimately residents back into rural areas. And family medicine is a great pathway to do it. So when I got to my third year rotation, I went, oh yeah, okay, this is where I'm supposed to be. And started interviewing and ended up thinking a little bit more about where do I really want to be, because I had some great options for where I wanted to do my residency training. And I thought, well, what's my goal? I still want to get back and work with Dr. Lawrence. So I did a rural rotation with him and another practice group here as a medical student, and then again as a resident, and started talking to them about jobs. And then I didn't come back right away.
I love these little segues to our eventual path of DPC, but when you're at this point of you get the chance to rotate with somebody who you see yourself being in the future, and then
Yeah.
you're like, oh, I am finding myself over here. What was it that, because I'm assuming when you say that you mean Montana and also New Zealand, like
Mm-hmm.
really far
Yeah.
out of Sandpoint, Idaho, but how did
Yeah.
you incorporate those points on your journey to DPC?
Yeah. So at the time of choosing a residency, I thought, well, I've always had this goal to get back to Sandpoint, or at least a town like it. And the medicine, the further away I was from the Pacific Northwest, how different was it? And so I ended up thinking, well, where can I go that I'm going to get good training and it'll be a new life experience for me? And Billings just had all the right criteria. It was also the only residency at the time in the state of Montana. And the only other residencies in Idaho were in Boise. Now there's one in Coeur d'Alene. There's a residency in Missoula. So the options now are much greater. But I just thought, well, I'm going to get closer to that type of patient and pathology and mindset that I am going to ultimately, hopefully, see in Sandpoint if I'm able to land there. And then I was closer to my folks and closer to my family. And that was important too at the time. So I went to residency in Montana. And in my third year, I did a rotation at Big Sky, Montana. And if any medical students are listening in their third year, take a look at that as an option to residents too, because it's a month-long ski rotation. So you work 7 days a week. You have to be in the clinic for 3 hours. Back when I did it, it came with a ski pass. So you get to ski half the day and you get to work the other half of the day. And lo and behold, there is a very good skier and capable and handsome orthopedic surgeon to be that I met on that rotation, and we just fell in with each other, and there was no questions after that. So I met my husband when we were there at Big Sky sharing that rotation, and he did his residency at shock trauma at the University of Maryland in Baltimore. He's from the East Coast. And I said, well, that's great. I love you. This is wonderful. But I took my first job out of residency in New Zealand because I needed a break. Residency training is difficult. For those of us who have been through it, it's fairly intense, and our patient population was very difficult. So I ended up going to New Zealand and working in another rural clinic just outside Christchurch on the way to the West Coast. Just a beautiful area, lots of farmers, lots of adventurers. It was really, really fun. But ultimately, because of my relationship with my husband, I kind of diverted a little bit before we came back to Sandpoint. So he did his residency in Baltimore. So after being in New Zealand for most of his internship year, I moved out there. And then when he finished his residency, I think he may have been a little jealous because he was going to work. I would talk to him at 9:00 at night and go to bed. And I'd sleep all night and I'd wake up and I'd go do my shift in the little rural clinic. And they have morning and afternoon tea. And afternoon tea was a built-in break. And I would call him on my afternoon tea on my WhatsApp or Zoom or Skype, I think it was back then. And when I had called him at 9:00 at night, he was driving to work. And when I called him at 3:00, he was driving home. And so on my days off, I'm going surfing or climbing or skiing or doing all these fun things. And I think that propelled him to want to go to New Zealand as well. So he ended up taking a fellowship in pediatrics and sports medicine. And we were there as a family with our 2 young children who were 5 months and just over 2 years when we moved there at the time. And we spent almost a year and a half in the country. And I worked in Auckland in a couple different family medicine GP groups. So
That's fascinating. And I think about some of my classmates in med school and then some of my husband's classmates in med school who went to ortho and they were Q2. And I was like, I don't understand what you just said. And like those of us who've been through residency, you know what
Yes.
that means. And that is every other day you're
Mm-hmm.
on call, which is absolutely freaking brutal. And to be
Yes.
to
Yes.
gosh, and you're
Mm-hmm.
just mentioning 9 and 3 a.m. I mean, like that's I'm sure there are other people blanking out on how impossible that sounds because it is impossible to maintain a
Right.
livelihood like that. Yeah.
Well, duty hour limitations started coming into be just before I started residency. So it was still a new concept. Then he would work 100-hour weeks. I would work 80-plus-hour weeks, especially on the hospital service. And it takes a toll. So for me, New Zealand was a breath of fresh air. And then going to Baltimore, I got the experience I think I really needed as a young attending to have the courage and the confidence to start a DPC practice when we ultimately ended up back here. So,
Awesome. I love it. So I want to ask here because the last person who was on the podcast who had gone to
mhm,
New Zealand was Dr. Amanda Dornfeld, and she went literally in plans to stay in New Zealand a bit and then come back. And then the
yeah,
pandemic hit for her.
yeah.
I remember her sharing how even in a different health system, she
Mhm.
was shocked at how like common guidelines like colonoscopy guidelines were not even a thing when she was in New Zealand in 2020. And so I'm just wondering, given that you have this exposure to rural medicine, you went
Mhm.
to a pretty well-rounded residency, and then you're able to practice even in a different country. What types of things made an impression on you practicing, especially in a different country, that you brought
Mm,
back to your DPC later on?
great question. I think practicing in New Zealand, which is a small country that has a structure that allows socialized medicine in and of itself is a really great model. People had access to care and it was affordable care. And New Zealand also has the ACC. And forgive me if listeners have heard this before, but it's an accidental policy for anyone who's in New Zealand anytime. So the surgeon does surgery on the wrong hand, or you slip and fall on the ice at the mountain, or you get a bee sting and it gets infected. All of those are considered accidents and covered by the ACC. So that was great because people in New Zealand were very self reliant and they would troubleshoot problems. And if they hurt their knee slipping on the ice, they would go see the physiotherapist or what we would call physical therapist before they'd come see us as physicians. I really, really liked that access. So being able to call your doctor, come in and see him, that was great. It was great on the primary care level. It is not great if you need a hip replacement. I remember I had a patient, this is in 2012, and she had had rectal bleeding, and I did an anoscopy procedure on her in the office, and there was a large polyp. It was about 3 centimeters. It was in her rectum, and I had to send a referral. They, for the most part, have a universal EMR, just there's a couple variations. And the GI team declined my request for a colonoscopy. And I don't know what the hiccup was, but I remember having to get on the phone and saying, no, I saw this polyp. You need to take this out. This is a cancer until proven otherwise, you guys. And they were just so overburdened by volume and use that the wait times were incredible, or they would prefer to give advice over the phone or via a letter rather than be able to actually integrate these people into a very, very busy schedule. So I didn't like that part. My experience in the rural clinic was interesting too. Same as in Auckland, actually. I worked in 2 GP practices in Auckland. I did not have a nurse. My exam room was my office. I had a curtain across the exam table that patients rarely, if ever, used. If we needed to do a breast exam, they just took their clothes off and I didn't leave the room. That's just how it was. But I only had 15 minutes. So any vital signs I wanted, I had to take them. And any problems we needed to cover, it was you get one. And if you have more than one problem, you book a double appointment, which is double the cost. And if you need to do more, you need to come back tomorrow. Now, the accessibility was there in the GP office, especially with a locum, because I didn't have my own continuity patients. But that time crunch, I also did not like because I want to talk to my patients and get to know them. And so if I'm just seeing a kiddo to check their ear before they go out of town for the weekend, you can do that in 15 minutes. But if you have somebody who's complex, you just can't. So there's pros and cons to how that worked. I really enjoyed it a lot. And if anybody's considering doing it, I would suggest it because it the other thing that it showed me was that you can have work-life balance, especially after residency. My jobs were shift work, sessional rates, sessional wages, and I could choose what hours I wanted to work. Typically, it was 8 to noon or 1 to 5, and it was as many shifts as I wanted to with the ability to take call if that was something appealing. And sometimes I would do fill-in work or nursing home work. Nursing home work in New Zealand was a joy. It was surprising how much I loved it because they don't have all the Medicare boxes to check. And you had a nurse that you partnered with, and you would make rounds together and you would troubleshoot the problems. And the patients had incredible stories. We had one couple who celebrated their 65th wedding anniversary when I was there and showed me their letter from the Queen congratulating them. And that was really a fun part. So I think that made you want to hear more stories. And I brought that back to DPC too, so that when I see a patient here, if I know they're chatty, I just book them in for an hour. And sometimes I say, seems like we should just get a cup of coffee and sit down, which is pretty fun.
I love that. And I love how you can so see the similarities when it comes to accessibility, when it comes to having a relationship, and when it comes to having the time you need with your patients. I mean, it's literally, wow, why does that sound familiar? Oh my God, that's DBC. That's amazing. So I love that. Now, let me ask you here because I don't know the answer to this. Whereas in the States, we have to find malpractice for, certain states that we're practicing in. Did you go through a particular like company or did you have somebody help you set up everything, including malpractice when you were doing locums in New Zealand?
I did not need malpractice insurance at all. So that was covered under the ACC in New Zealand. So I could elect to get additional coverage or do additional training if I wanted to, but I did not elect to do so, and it hasn't been an issue. I think when we're young doctors, sometimes we do a little bit of CYA medicine. I think as older doctors, we do that too, right? Because there's always a scenario where you don't want to get into any trouble. But even just taking that heat off as a young graduate felt amazing.
Totally. I can absolutely see, I just picture like the person who is really scared to open a DPC because they are
Mhm.
not sure about malpractice, even within the States. This is not
Yeah,
even foreign. So
right.
yeah, so that's great. Great to
Mhm.
know. Now, how did you guys then migrate back to the States and then to Sandpoint after your time in New Zealand?
Well, before we left for New Zealand, my husband was finishing residency and we sold everything that we owned. And we packed into 200 pounds in a couple of boxes that shipped on Amtrak in a car full. That was it for 4 of us. It was wild. And while we waited for him to finish his residency and study and take his board exam, we moved in with my mom and dad in Sandpoint. He ended up talking to the local hospital and they said, yes, we have room. We'd love for you to come back. Can we hire you as an orthopedic surgeon? Which made me say, this is actually feasible, but we can't come back until we're done in New Zealand. That's going to be at least a year, if not longer. And I started to talk to all the family practice options in Sandpoint. One was a federally qualified health center, one was a private practice. And they're great. There were people that I had met as medical students and as residents. One of the doctors in the private practice remains my neighbor, a different neighbor than Dr. Lawrence, actually. And so it's a small community. And I was ready to take a job with one of those practices until my mom said to me, hey, my coworker said you should go meet Dr. King. I said, who's that? I hadn't heard of him. He'd been doing DPC for a couple of years, but he had been doing general practice for many in the community. I said, oh, okay, I'll go talk to him. And I remember sitting down with him in his office and him telling me what is DPC and how his practice model works and saying, this isn't real. This doesn't make sense. No one talked to me about what DPC was or even the possibility in residency. And I said, can I come back tomorrow with my husband? And we came back the next day and he told my husband, and my husband looked at me and he said, this is what you should do, because he was going to start his job and it would allow me to start and grow a practice from zero. So that was a blessing at that time. But also Dr. King has been such a lovely and supportive partner. I really couldn't have gotten any luckier with him. especially to start and grow a DPC in a thriving model that was already doing fairly well. So we ended up contracting and negotiating over FaceTime while we were in New Zealand and kind of getting a plan together so that when we came home, Jonathan started his job with the hospital. I had about a month to transition my kids into their preschool and daycare, but also be their mom, get settled into our new house, and then slowly start chipping away at the building blocks of the practice and starting to see new patients.
That's awesome. And I wonder here, just because Dr. King is in practice, you're learning about DPC, you guys are
Mhm.
coming together over, that's amazing how you guys connected. I love that. But when it comes to just knowing that it was going to be okay for you guys to partner, I wonder about that because there's a lot of people who are like, oh, now more people are wanting to join a DPC versus starting their own. And
Mhm.
so when it comes to any high level tips that you have for feeling each other out to see, is this a good relationship to go into, to try?
Yeah, I was probably pretty naive at the time. I didn't really know. I didn't really suss him out. But what made sense to me at that time was that he and I were growing parallel practices. So he had his own business in LLC, and he hired me on as a 1099 contractor. And then I was able to create my own PLLC and grow next to him. That meant that in the first month when I had 10 patients, I had 10 patients. But that meant when I was full 2.5 years later, I was full. And over that time frame, we were able to really make our office more efficient and trim down some of the costs that we didn't need. We ended up hiring a really wonderful medical assistant who I always tease is worth her weight in gold. She's been really helpful in getting us more digital or using our EMR or lab interfaces to the best of its capability. So it's been a growth project, definitely. And I wouldn't turn back. I don't think I'll ever enter traditional medicine ever again. And I would encourage people who are thinking about DPC to look closer. Now, as far as finding a partner, that has been an interesting challenge. So my partner's thinking about retiring and it's been tricky. It's been tricky because there's so many options. Just there's so many places to get your news. Can you get it on social media? Should you get it on Fox News? Should we be reading the paper or our phones in the morning when NPR breaks their morning edition? There's so many options. There's also so many options for where to look for and recruit a physician. Is it talking to the local residencies? Is it recruiting online? Is it actually using a recruiter? Is it by word of mouth? We've had a number of doctors come through looking for work, and we've been pretty close a couple of times to have somebody join us. And for one reason or another, it hasn't worked out, whether they weren't ready or we couldn't offer them a full practice out the gate and they didn't want to take a pay cut. And that's really hard if you're the primary breadwinner to say, okay, I don't have a full practice and I'm not going to be making the same money I was in a traditional hospital practice, but it's so worth the wait and it's worth taking that hit because in the long run, the work-life balance is so beautiful. And you're your own boss and you can make your practice be whatever you wanted it to be.
I think it's so important that you mention that, especially for those people who are in that situation and they might be able to take those words and brainstorm differently in order to make this
Mhm,
happen, to be a DPC doctor. So I think that's
mhm,
wonderful that you shared that. When it comes to the community, given that you were from Sandpoint, you even went back in a buffer and stayed with your parents when you initially moved back. Were you known in the community in terms of, "Oh my goodness, I'm so excited that she's coming and she's gonna be a doctor. I'm signing up today." Or did you have any, just because I think of with Dr. King already there, like, did you
mhm.
even have your own, "But what is it that you do?" type of question?
Yes, I think all of it. So there were some folks who had been waiting for me to come back, and there was a wait list when I came, right? So the first month I had 10 patients. There Surprisingly, with the growth of the town, there are a number of patients I don't know. I've never met them. I've never seen them in town, and they've lived here for 10 or 15 years. I was gone for over 20 years before coming back to set my practice up. And then there's some people that I'll see in the office and go, "Oh, wait, what year did you graduate? I think you went to school with so and so. Do you remember? And that's kind of funny. I actually have a Sandpoint spiel I give to the locals that I recognize because small towns are small towns. And I say, hey, we went to high school together and we know a lot of people in the community jointly. I just need you to know that what happens in this office stays in this office. We take confidentiality very seriously. This is a safe place for you. I'm not going to talk about things that we talk about anywhere else. And if I see you in the community, I want you to come and say hi to me first so that you feel comfortable and I know that it's okay to give you that acknowledgement. And it happens. It happens in the grocery store. It happens at the farmer's market. It happens at the kids' sporting events. And sometimes it's funny because people will come up and start talking about something that is probably not appropriate to talk about in a room that's full of people. And sometimes people will call and say, or come over and say, hey, I need to call you. I need to come in. And then I go on my phone really quickly and I find them in my record. Then I put a task to my assistant and say, please call them for an appointment so that we can get them and have them come in when they need to be seen.
I love that. And it's already hitting on point, even just in your opening days about accessibility for your patients. So that's awesome. And
Yeah.
when it comes to this idea of what do you do as a, like, what is DPC and also this influx of patients into the community or influx in members of the community, I should say, did you find anybody who was like, I already had a DPC doctor in the state that I came from, and now I want you because you do DPC specifically?
Yes. Yep. A lot of people will self-recruit to the model because they have experience with DPC. I find my role here in Sandpoint is variable. So I have some Medicaid patients in my panel. I have many people who are seasonal workers. We're a Four Seasons town with a ski hill and a lake. And they come in and they say, I make a good wage most of the year, but because I work at the ski mountain, I don't get insurance. Or because I work doing landscaping in the summertime, I make a great wage, but my job doesn't provide any sort of benefits. And so those folks may not qualify for the state funded premiums, or they may qualify for a catastrophic plan. Common, this happens in DPC, and they come see me. And I think more so what happens lately, now that my panel is fairly full, is it's patients who no longer trust in regular healthcare. And they feel that their doctor doesn't have time for them or their doctor doesn't listen. I get that. When I was in New Zealand and I saw one patient in 15 minutes and took all my own vitals, you know what I did in order to maximize that time? I took notes on my computer and typed the note as we were talking. I essentially took dictation. How present can you be in that moment if you're doing something like that? And so patients will have heard about our model and that we don't have computers in the room. We sit with a clipboard and we listen. And if you come in with a list 15 things long, we're going to just say, can I see the list, please? And go through it one by one by one. And Fraser and I are very compatible in that manner as well. So our practice styles are pretty similar when it comes to providing patient care. And I think you can only know that after time in the saddle with somebody because you can ask them, hey, how would you approach this problem? Or do you get your notes done on time? Or what was a difficult scenario with a coworker? All those interview questions. But you just don't know until you're doing it.
Very understandable. And I definitely think that there's lots of great examples, even on the podcast, of people who have partnered together or people who are married and practicing together. It's definitely, I am completely with you in that you don't actually know until you try it. And I think that the way that you guys did it, how you were a 1099 coming on, I think it's a very reasonable way to explore a relationship without getting married on day one, so to speak.
Yes.
So yeah, that's
Yeah.
awesome. And when it comes to just, I wanted to call out one tagline on your website because this really, for me, it makes me like super excited to ask you about your wilderness medicine fellowship. But it says that you guys are delivering a different kind of healthcare. And so, as you've spoken about how people are really leaning into the way that you deliver care, the
Mhm.
relationship, the really personalized focus of every single visit, how does your fellowship in wilderness medicine play a role in all of this? because especially you're in a place with a ski slopes and a lake.
Yeah. So I think the tagline on the website, when we first started doing DPC in Sandpoint, Fraser, I think, started in 2015 and I started in 2018. We really were some of the first practices in the United States. And now there's so many people are headed to the DPC direction. So part of it was talking to that, right? And is DPC really a new frontier? No, it's an old frontier. It's the medicine my grandfather practiced in 1965 without insurance companies playing a role. But when we talk about wilderness medicine, how does it integrate into my practice here? A lot of it has to do around travel planning. So I'll have travel consults. I will have people who return from travel with rashes or an injury or something that was managed overseas that needs more TLC or care. And then I have a lot of people out there having fun. So they have a tibial plateau fracture skiing or tear their biceps water skiing, or they have a tumble on their mountain bike and they need to get wound care. And we have them come in every day for their giant abrasion or whatever that looks like. And that's pretty fun. But wilderness medicine is medicine in austere environments. So realistically, I'm using wilderness medicine more so for the fun stuff. But one of the themes is, what do you have and what do you need, and how can you make what you have meet your needs, even if it's something not that appropriate? For example, I gave a talk to the residents just last week down in Coeur d'Alene on casting and splitting in the wilderness as part of one of their afternoon didactics. And I said, look around. What do you have? I picked up some sticks off the ground at the park where we were at. I pulled my backpack panel out of the backpack I used to have my gear. Hey, you can make a pretty good splint out of a backpack panel that's padding for those 2 sticks that you're going to wrap with a t-shirt. That's not a SAM splint. That's not a thumb spike or wrist brace, which we don't hike with. But it's pretty fun to integrate wilderness medicine, maybe not formally, but in those other tangential ways.
And I just think about like the times that I've talked about practicing overseas, specifically when it comes to female exams and like the things that we've had to do on whatever makeshift thing that we could do for pap smears in the Dominican Republic. Like I
Mm-hmm.
think about the times that like this is nothing necessarily to do with helping, with particular diagnosis or treatment, but it's like when the electricity goes out and you have to use a headlamp in your clinic
Yes.
and like you make a light, you make light of it rather than be like wanting to die and sweating because you're so nervous. You're like, what is my patient going to think about me? Like, I think that these things that we have in our pocket ready to go are also so great for family medicine because we never know what the heck we're going to see.
Right. Or they might come in saying, hey, I hurt my wrist. And then all of a sudden you're having a totally different conversation. We've all been there in our day-to-day practice. Okay, let's break that down. Good thing we've got extra time today.
Absolutely. Oh my goodness. And when it comes to when you talk to the residents, I just wonder, did they lean into your way of practicing, being a DPC doctor more because you're bringing this, oh my God, she's a family medicine doctor and she's doing this stuff with her backpack. This is amazing. What kind of doctor are you to be able to do all of this?
I would like to poll them and see what they said, but I did plant the seeds with the interns and say, "Hey, you guys come up and rotate with me. Come check it out, see what it's like." Because I wish I would have had someone say that to me. I wish I would have had in some point in training someone say, "Hey, running a medical practice isn't about signing a contract and becoming an employee. You need to think about HR. You need to think about savings. You need to think about retirement. You need to think about business efficiencies. How do you find a good accountant? All of the things that as you're growing your DPC practice, you're going to be forced to learn, but it's nice because you'll have time to learn it too if you put your mind to it and work hard.
And especially just thinking about how you started with a wait list of 10 people, which is awesome, but it's also super more manageable than 200
Mm-hmm.
people on your wait list. So I think that
Mm-hmm.
that's awesome. I love how you mentioned your Sandpoint talk that you give to people who you may have known growing up. When
Yeah.
it comes to just maintaining relationships, what do you guys do in order to like make sure that people know it's an open door? Because I don't know if you get this, and especially you might see it more in the people who have migrated to Sandpoint, but I will be like, You pay me every month, and you could have called me for that thing that's not like I had a keratoacanthoma, and it's like my patients are like, yes, we were waiting in the urgent care for 8 hours, and they told us that it's an emergency. We need to go to the emergency room. And I'm like, oh my gosh, like this type of stuff where we have to remind our patients, like, hey, remember, I'm your doctor over here. Do
Yeah.
you what do you guys do to lean into this? We are here to build relationships with you.
Yeah. So when we have new patients come in, I give them another spiel. And part of that spiel is you're going to get my business card with my emergency after hours cell phone. And I want you to call me. In fact, most of the time, I kind of get grumpy with my patients because they don't call me. And I say, why didn't you call me? You have my cell phone number. And I have a spectrum of patients. I have one patient who says, I am paying you each month for your cell phone number. So if I ever call it, I want you to answer. And I don't see those guys. I can think of at least 3 of them. And then I have patients who I see every week or 2, and that's okay because they're in crisis or they're dealing with a new disease or a new diagnosis. And I say, if you have problems tonight, I want you to call me. And again, they usually don't call me and it's fine. But that's one of the fears that people have. Patients have the fear. How do you ever get time off? You're on call 24/7. I don't ever want to bother you. But I also have young doctors or nurses or other clinicians in the community say, I don't understand how you do it being on call 24/7. And most patients are so respectful. But we will reach out to them. So using our EMR, we have a series of future-based tasks so that we keep tabs on them and we don't drop them. So if somebody is due for their follow-up imaging of an ovarian cyst, we have that reminder come up 6 months later and we say, we've sent your order, you're due. Or you're due for your thyroid labs. We just changed your dose 6 weeks ago. Please schedule a non-fasting test. Or it's been a year. You're overdue for your yearly labs. Please call to get in for an appointment at your earliest convenience. And I think people really like that because in this busy world, we have things coming at us and push notifications all the time. So we're A, kind of used to it, but B, sometimes overwhelmed and we forget about ourselves in the midst. And having a little bit of a reminder or more of a TLC, I think works and helps.
Absolutely. And I think that it also this leads me to my next question. That level of care has probably also led to you guys being full as a practice. And so I'm just wondering,
Yes.
yeah, I'm just
Yeah.
wondering here when it comes to dealing with, hey, are you open? I'd like to join. What do you do? Because right now you're full. I know you mentioned Dr. King may be looking at retirement soon, but like,
Mhm.
what do you do to maintain those leads?
We've done variations over the years. When Dr. King first started talking about backing off to part time, so he and I were full together at the same time, and we actually just closed our practice. And online, we said, if you're interested in joining us, please call. And we screened our patients to come in because some people will try to come in and they'll go, wait, what? It's a year contract? I thought it was $60 for one visit. No, that's not how it works. And then we've wasted everybody's time. And then some people still are confused with the fact that I don't take insurance, but I'm an ordering and referring provider for insurance. And we try to clarify those things. So there was a first pass on the phone. Then for a while, as his numbers were dropping down and I didn't have patients just through natural attrition with people moving or having life-ending situations, I dropped down a little bit, but at the time I didn't really mind because my kids were in school and there's all of these other things happening. But recently we have reopened our website so people can sign up online. We tell them when they sign up, we call them that same day, welcome to the practice. We are so happy that you've joined us. Just so you know, your new patient visit is 3 to 6 weeks out. But if there's an urgent matter that comes up, we can get you in for a quick visit before we do the full hour-long visit, and that helps. And we've had a slow trickle of patients. I am really optimistic. We're going to have a provider join us this summer. Fingers crossed. But if not, I'll ping you so you can say, hey guys, remember that interview? Go talk to Dr. Klaucke. And so when that happens, that's going to give us a whole different dimension because we'll have my partner, Dr. King, who's part-time, and then someone else coming in part-time too. And that'll allow some more growth. Idaho is a very interesting state to practice medicine. And unfortunately, what's under threat right now is the Medicaid expansion. That was passed by popular vote a couple years ago. The citizens of the state voted for and passed Medicaid expansion, and now it's back on the chopping block. And if that happens, a huge number of patients are going to lose their insurance, and I'm not sure we're going to turn to. Our FQHC is bursting at the seams. There's no OB or GYN care in my community. There's actually a podcast about that on This American Life. One of our OB/GYNs was interviewed. It's heartbreaking. And so it'll be interesting to see where things go in our community and in our state with regard to what care is available and how much people can access it. And I think DPC is going to potentially become even more appealing if things go the wrong direction with what's available for care for those who are really at need.
I absolutely agree with you that this is why DPC is so appealing. So I love that you're doing this. I definitely would say like I am like setting all the good juju. Like I hope that that person starts working in the summer because not only does your community need it, but also what community does not need more primary care access, but also just to be with you and Dr. King, who are so like-minded already with just being in the community and taking care of them, taking care of your patients in this relationship focused way. So I love that. And I think about like the next thing that I want to ask is, can you give the audience an example of like only in DPC could this have happened?
One day, this was probably 4 or 5 years ago, I had a patient come in to see me, and she had seen me a few times, relatively new patient, 6 months in, something like that. She had a couple of things, like a little high blood pressure, a little acid reflux, a little bit of anxiety. But she made her list because it'd been a while since I visited with her. And her list, I think, was about 13 items long. And we started going through the list, and I was very glad I had the extra time, which I went over, which was not a problem because our patients get it. They know that if I'm with them and they need time, I'm going to give it to them. And if I run a little bit late, we're either going to call or text them, or that's okay. Our wait times are never usually more than 15 or 20 minutes. Oftentimes we run right on time. And we got to number 13. She says, "So I have this spot on my leg. Can you please take a look at it?" And I said, "Sure." I was not expecting a gnarly 1.5 centimeter raised pigmented lesion that was a melanoma until proven otherwise. And all I thought was, this should have been number 1. And I said, that needs to come off. I'm going to do a punch biopsy. I'm sorry, I know this appointment's taking a little longer than we both anticipated, but we're going to do that right now. And I called my assistant and I said, please set me up for a punch biopsy. And we took a piece. Thankfully, it wasn't. But I ended up removing the entire lesion because I took a piece and we could have missed something. And she was so thankful. She's also glad that it was gone because it was fairly unsightly. But that could only happen in DPC. It was slowly and systematically get through that list and you get to number 13. And then have a plan in place that you can execute right then. Because in my traditional practice, when I was in Baltimore, I was an employed physician. I was one of 9 in a hospital-based practice, clinical practice, outpatient. And my wait time was 4 months long. And if patients were sick, they never saw me. I did not have time to do anything like that. I had 20 minutes per patient. Oh, and by the way, if I had any no-shows that week before, they would count up how many no-shows I had. So if I had 1 no-show per session in the morning and in the afternoon, that would be 10 per week. And I would somehow have to overbook myself by that percentage of no-shows because they probably were going to no-show me on me again. And now all of a sudden my work hour, I would put on roller skates and it didn't mesh with my personality. And that could have never happened except for in this moment in DPC. It happens, like we joked about at the beginning, they come in for wrist pain and you're down the rabbit hole of something totally different by the end, but very important nonetheless. And I think that builds trust when patients feel like we can talk about things. Or I had a patient who came to see me as a new patient, and we were talking about something very benign, acid reflux. It wasn't until 45 minutes into the visit that we got to the real reason that she was there. And it was emotional and traumatic and contributing absolutely to her reflux. But if I would have been in my new patient 20-minute visit, who knows? Then my follow-up would have been 6 months later, and good luck. So DPC just offers that time. And I think that's one of its greatest strengths.
And I love it. It's going back not only to what you were picking up on when you were in New Zealand and just
Mhm.
your time prior to that, but also I just wanted to call out here how you said, "I'm sorry, your appointment's gonna take a little longer than you thought." It's not that, like, the patient is pissed off because you can't spend enough time with them. You're saying to the patient, like, "I'm
Yeah.
so sorry, we're gonna take a little bit longer here." And that's totally I don't like, if I ever said anything like that in fee for service, it would be because, like, something needed to be addressed, but it's like, you also have this massive guilt of you're putting everyone else behind. You're never gonna
Mhm.
be done on time. You know that
Yep.
everyone's gonna be mad at you as soon as you see them in their next patient in their next
Right.
visit. Yeah,
Yeah. You're going to be late to pick up your children at the daycare. You're going to get a fee because you're late. Then you're going to hit traffic. I mean, it just all snowballs.
crazy, crazy. You talked about how your husband and you sit down with Dr. King and you're like, this is really amazing. I think I want to do it. And we talked a little bit about potentially financially preparing, knowing that if someone is the
Mhm.
primary breadwinner, hey, this is one way to think about doing DPC. But
Yeah.
I'm wondering in terms of other things that you would recommend people thinking about if they're either hybrid, there's some DPCs that are still hybrid,
Mhm.
that have not opted out of Medicare, or the people who are thinking about DPC in terms of residents to people who are 20 years in, what other things would you just mention to people or call out to people to really think about work-life balance, finances, and
Mhm.
what else? Because I think that, again, you are a rural physician like myself. You're a person who really loves the accessibility, the time with patients and the relationship. So anything else that comes to mind?
I have found the DPC community in general to be very, very welcome. So there are 3 DPC practices south of me in Hayden, which is about 45 minutes, in Post Falls, which is about an hour. And we got together as a group of doctors when I first moved here and had supper and talked about it. And if you have any interest in DPC, if I have someone cold call me and say, "Hey, I'm so and so, and I live in Florida, and I just want to hear more about," I can schedule time to talk to that person. And I'm not going to be like, "Ugh, why did you get in touch with me?" It's going to be more, "This is my baby. I'm so excited about that. And your life is going to change." You can't understand how much until you're doing it. And some of those harnesses are off of you. For example, the time limitation or the fact that my kids have soccer at 4 o'clock on Mondays and I block myself out at 3:30 so I can take them to soccer, or I block myself out on Tuesdays at 2:15 for half an hour so I can pick them up from school because they don't have anybody to go get them. And that just creates less stress. We have a lot to manage as physicians. We have a lot to manage if we are part of a family. We have a lot to manage just to stay board certified or to keep up with your CME. And TPC allows you to carve out the time and space to do those things. But I think your question is, what else should people keep in mind when they're thinking about DPC? It's not a quick and immediate reward for most people. It's a slow burn. And you need to think about what your 5 year and your 10-year goal is and what your plans are. And you need to be committed to the model, because if you say, "Oh, I'm going to start a DPC," and you're in the red for the first 6 months and barely breaking even for the next six, and then kind of turning a profit for the next year, depending on what your student loans are like, or depending on what your other obligations are, you have to put the time in and do the hard work and take the risk. And that's really scary. But if you have a 5-year plan or you have a 10-year plan, or, okay, I got this loan at this much interest percent. If I pay this down quickly, then that goes away and I can use, you have to be thoughtful in your approach to starting a DPC and have a good idea of where you're at financially and where you are within your practice. So someone fresh out of residency starting a DPC practice, you could do it. It would be a much steeper slope to climb than someone who maybe has a little bit of savings or can join an already existing DPC or has a practice that's going. So you're already in a community and you have 2,000 patients. You might take 200 with you. That's kind of the quote DPC. You might take 10%. So you gotta play the long game a little bit.
Thank you so much, Dr. Klaucke, for joining us today. Your episode is coming out almost middle of the second quarter. It's like that extra boost in energy just hearing your story. So I'm so grateful for you sharing it.
Yeah, you're welcome. Thank you so much for having me. I feel really, really thankful every day to be part of a DPC practice and to be a mom and to be a physician and to be in the town that I'm in and the community that I'm a part of with that training. So I really appreciate you giving me time to talk about all of that this afternoon and share my story.
Thank you for listening to another episode of My DPC Story. If you enjoyed it, please leave a 5-star review on your favorite podcast platform. It helps others find the show. Have a question about direct primary care? Leave me a voicemail. You might hear it answered in a future episode. Follow us on socials at the handle @MyDPCStory and join DPC Didactics, our monthly deep dive into your questions and challenges. Links are at mydpcstory.com. For exclusive content you won't hear anywhere else, join our Patreon. Find the link in the show notes or search for My DPC Story on patreon.com. For DPC News on the Daily, check out dpcnews.com. Until next week, this is Maryal Concepcion.